Good morning, and friendly welcome to the first roundtable of the 13th International Conference on Kangaroo Mother Care. We wish every one of you could feel like at home. In this roundtable, we are going to discuss about immediate kangaroo mother care and science. I am going to ask for the speaker that came to the roundtable, and meanwhile they are arriving here, we are going to highlight two details that are important for us. Please remember that posters will be available in the poster area, so remember that you can place them, and at the same time, it's important for us that you count the remaining posters, and remember that you can vote for 3 of them, so that at the end of the Congress, the 6 most voted posters will be presented at the end of the Congress to the rest of the audience. And the second detail is that translation devices that you are using should be left in the exit area before the coughing time. So it's an honor for us to share this topic with this very well-known team of neonatal nurses, neonatologists, and scientists. They are Laila Kristoffersen from Oslo, Norway, Agnes Liner from Stockholm, Sweden, Niels Bergman from South Africa, Luong Kim Chi from Vietnam, and Juan Gabriel from United States. So we are looking forward to hearing them. We are not going to spend more time. Remember that at the end of this roundtable, we will have 15 minutes to discuss and to open the discussion to the rest of the audience. So we will start with the first talk. So please, Laila Kristoffersen, it's your turn. She has been working as a neonatal nurse at Olav University Hospital in Trondheim, Norway, for the last 30 years. The recent years in combination with a PhD degree at the Norwegian University of Science and Technology. Now she has a postdoc position as associate professor there. She's going to talk us about immediate kangaroo mother care and about her experience in Norway. So when you desire.
Thank you for the introduction. And good morning, and thank you to the organizing committee for inviting me to present experiences from Norway concerning immediate skin-to-skin contact for preterm infants. First, I will shortly introduce you to Norway, where I come from, how the neonatal care is organized, and a few words about the use of immediate skin-to-skin contact in my country. Then I will present preliminary results from our study on skin-to-skin contact for very preterm infants, and finally some thoughts after we completed the study. So, in the middle of the red circle, you can see that Norway is located in Scandinavia, and Trondheim is located in the middle of the country. Approximately 5 million people live in Norway, of which 200,000 in Trondheim. And this is Trondheim. In the middle of the red circle, you can see that St. Olav's Hospital and a part of NTNU, which is the university, are located. Norway has 5 university hospitals, of which 4 level 3 and 1 level 4. Altogether, there is 20 NICUs in Norway with different level of treatment for preterm and sick newborns. In the last decade, an increasing number of hospitals in Norway have changed practice and are facilitating skin-to-skin contact between the mother and the infant in the delivery room. These units offer skin-to-skin to infant older than 32 weeks, who are vaginally delivered and not in need of breathing support. 15 years ago, St. Olav's Hospital changed the routine to a non-separation approach in the delivery room, from gestational age 32 weeks following vaginal delivery. From a study we conducted, we realized that a quite high number of infants in this gestational age were delivered by C-section due to maternal reasons such as preeclampsia. However, we wanted to facilitate skin-to-skin contact between mother and infant also following C-section. and if the infant needed CPAP. Since 2013, the procedure was changed, and immediate skin-to-skin contact has been standard practice also in this group. Based on the positive experiences from the study and the change of practice thereafter, we wanted to extend the practice to even younger infants. Therefore, we planned a study involving very preterm infants, and the protocol was published in 2016. And these are pictures from simulation-based training prior study start. In preparation for the study, all involved professionals attended simulation-based training or skills training in advance. The training was designed to replicate the procedure from the delivery to the infant being placed in skin-to-skin position or incubator. We also developed checklists prior to the study describing what is to be done, when, where, and by whom. And this safety checklist was a part of the procedure during the study. So, these pictures exemplify the procedure from informed consent being obtained before delivery, then the delivery, and the procedure from the infant being randomized to skin following a C-section. At St. Olav's Hospital, we have a resuscitation unit inside the delivery room and operating room, as you can see on this picture. And this is from the simulation-based training prior study start. Following delivery, all infants were placed on the resuscitation unit for initial assessment and stabilization and monitored with electrodes and a saturation probe. Infants with birth weight less than 1,500 grams were started on parenteral nutrition, and infants with gestational age less than 30 weeks received nasal CPAP by default. This is one of the included infant at St. Olav's Hospital, randomized to skin following a C-section. The infant had a gestational age of 29.0 weeks and a birth weight of 1,100 grams. According to checklist 1, as you can see on the right, due to weight and gestational age, the infant received CPAP and parenteral nutrition. After the mother was transferred from the operating table to a bed in the operating room, the infant was placed in an upright position between the mother's breasts. Irrespective of randomization to skin or standard care, the infant was covered by a plastic wrapping bag and warm textiles for temperature preservation. Thereafter, the infant and the mother were transferred to the recovery unit accompanied by the medical team. And the neonatal team comprised a consultant in neonatology and at least one neonatal nurse. The neonatal medical team supported the infant during the transfer from the operating room to the recovery unit, and a midwife and anesthesiologist supported the mother. After finishing checkpoint 2 in the recovery unit, on the lower left, the neonatal consultant could leave in agreement with the neonatal nurse in charge of the infant. The consultant was easily available on short notice. And checkpoint 2 was conducted in the NICU if the infant was randomized to standard care. In this picture, you can see a midwife helping the mother express milk while the infant is in a skin-to-skin position. If possible, we want the infant to receive colostrum in the mouth as the first meal. The mother is using a mirror to be able to have a close look at her newborn. After a maximum of 2 hours, the infant was transferred to the NICU in an incubator. At the conference in Trieste in 2016, where I presented the ongoing study with the aim to investigate short and long-term outcomes in preterm infants receiving skin-to-skin versus standard care after delivery. Important papers have been published on this topic from both low, middle, and high-income countries. However, I would like to share with you some preliminary results from our study. We stopped inclusion after collecting data for 6.5 years in October 2020. The study had a design as a multi-center randomized controlled trial, and we included preterm infants with gestational age 28.0 to 31.6 weeks delivered by vaginally and by C-section. The infant had to have a birth weight of more than 1,000 grams, and infants were excluded if they were in need of more than 40% oxygen to maintain oxygen saturation above 90% after 20 minutes. Infant or mother in need of mechanical ventilation or infant with major congenital malformation were excluded. This figure illustrates the primary and the secondary outcome from delivery to 5 years. We are collecting data on the mother and the child from birth until the child is 5 years of age. The primary outcome is the cognitive score at 2 years corrected age measured with the Bailey Scale of Infant and Toddler's Development. And beyond that, we are collecting data from birth throughout the hospital stay. We are also collecting data on mother's mental health at 3 time points. We have parental questionnaires about the child's psychomotor development, general movement, nutrition, and behavior during this time span of 5 years, as you can see. Today, I will present results on secondary outcomes from delivery until 24 hours, including safety, feasibility, and physiological stability. Eligible participants consisted of 427 women, in which 16 declined participation. In 43 cases, informed consent was not obtained due to lack of time before delivery and lack of staff or crowded department at the time of delivery. Then we had consent from 368 women, of which 229 were not included, mainly because they delivered after 32 weeks of gestation. So, we had 139 mothers who delivered 149 children, of those 10 twins. 41 infants was excluded due to low birth weight, mechanical ventilation, high oxygen requirement, etc. 108 infants were included in the study, 51 were randomized to skin-to-skin, and 57 to standard care. The demographic and neonatal characteristics of included infants are seen in this slide. All infants had antenatal steroids, and the proportion of C-section was equally distributed between the groups. A majority were male, and mean gestational age was around 30 weeks, and mean birth weight just over 1,400 grams. Infants were randomized at a median of 25 and 23 minutes of age, and directly after randomization, they were placed in an incubator or skin-to-skin with a mother. In this study, we defined hypothermia below 36 degrees centigrade and the need for mechanical ventilation within 2 hours after randomization as safety outcome. And as you can see, there was a small but not significant difference in the incidence of hypothermia within 2 hours after randomization. This is in the time frame when infants randomized to skin are placed in a skin-to-skin position with a mother. None of the included infants needed mechanical ventilation the first 2 hours after randomization, and there were no adverse events in any of the groups. Infants in the intervention group were in skin-to-skin position for a median of 120 minutes. In 14 mother-infant pairs, skin-to-skin was interrupted before 2 hours. 4 of these were due to increased oxygen requirement, of whom 3 received surfactant in the NICU. Maternal causes represented 8 cases, where pain, need for a refresh, etc., was cited as the cause. In this time plot, in which data is registered every 15 and 30 minutes for the 2 first hours, then hourly, you can see that the difference in heart rate, respiration rate, and oxygen needs during the first 24 hours are the same between the skin-to-skin and the standard care group, with an initial decrease in heart rate and increase in respiration rate. And here is some findings from discharge. This picture is from a home care, as it is facilitated by St. Olave's Hospital. Here you can see a nurse from the NICU to the right, together with the father and the infant being weighed. An interesting findings was, independently of gestational age, a significantly higher proportion of infants randomized to skin were discharged with a feeding tube to home care compared to those randomized to standard care. And we can just speculate that a non-separation approach might lead to more confident parents, which again leads to an early discharge from the hospital. So, to summarize the safety outcomes, which include temperature and the need for mechanical ventilation the 2 first hours after randomization, other studies have shown better temperature preservation in favor of skin-to-skin contact. We also found fewer infants in the skin-to-skin group with temperatures below 36 degrees centigrade. And regarding the feasibility, in our study, we found that immediate skin-to-skin between mothers and very preterm infants was feasible following vaginal delivery and C-section. We think that one key to success was that the medical teams had attended simulation-based training or skills training designed to replicate the procedure from the delivery to the infant being placed in a skin-to-skin position. Another one was the detailed checklists. Skin-to-skin has also been shown to enhance parent-child bonding. And a recently published qualitative study on the same data showed that mothers who had their infant in skin-to-skin shortly after delivery described how they were immediately comforted by the infant's vitality. And the poster is upstairs. So, what was the prerequisite for successful implementation after ending the study? After ending the study, 2 of the 3 participating hospitals, participating units, have immediate skin-to-skin as a part of standard practice from gestational age 28. Our experience in Norway are that although it was feasible to provide skin-to-skin contact both in the delivery room and operating room, the availability of trained personnel was a barrier. At one of the collaborating hospitals, this was very challenging. We saw that to be able to facilitate skin-to-skin in the delivery room and operating room, this may require a redistribution of available resources for a period, and maybe in particular nursing resources. Facilitating skin-to-skin in the post-operative period can be demanding and presupposes extended cooperation among more professionals than usual. This includes midwives, gynecologists, anesthesiologists, pediatricians, neonatal nurses, and nurses in the recovery unit. A change in clinical practice also has to be rooted in leadership, both in the medical and in the nursing management. It is important that the leaders emphasize this practice as wanted and important. We also see that commitment, stubbornness, and enthusiasm are necessary when implementing a comprehensive change in clinical practice. Last but not least, a motivation for making the effort on providing immediate skin-to-skin contact between the mother and infant is that it might be the best way to start life as a preterm infant. And even though early skin-to-skin in the delivery room and operating room may not increase survival or reduce major morbidity in preterm infants in high-income settings, our impression during the present study was that parents had a strong wish to hold and to touch their infant as soon as much as possible after delivery. Thank you for your attention.